Okay, we're back. So moving on, EFM is an electronic fetal monitor, and these are old dates, but they're still from that time. There's nothing new. And basically, this was kind of sad for a lot of us because when they first started with the electronic fetal monitoring, we thought they were going to save a lot more kids and have, smaller NICUs and less cerebral palsy, less bleeds in the brain because it was going to alert us to rough waters ahead. But basically, and here it is, and this is from A1. This is the big nursing for obstetric neonatal nurses. There is no benefit to continuous electronic fetal monitoring for low-risk women. Continuous electronic fetal monitoring is associated with a high rate of cesarean birth. Why do you suppose? Because we have a tracing and the doctors are afraid they're going to get sued because it's a very highly litigious area, when a lot of times all we'd have to do is what we call labor down and work with them so that wouldn't happen. And then here we go. I made an analysis of just a ton of random controlled trials, and you know what those are. There are many, many, many. The use of electronic fetal monitoring during labor did not show a decrease in cerebral palsy, less frequent occurrence of low APGAR scores, and that lets us know how the baby's doing. Less frequent NICU admissions, or a decrease in infant mortality. So there you have it. Yet we put them on everybody, and all it's done, I think, is make the area a little bit more litigious. Okay, before we go on to that, let's stay here for a while. Continuous internal fetal monitoring. The advantages are we do see early detection of abnormal fetal heart rate pattern. They can suggest fetal distress, not all the time, but it can suggest it. Accurate recording of uterine contraction intensity, and that's very true. It lets us know how strong the contraction is in the lining of the wall of the uterus. Recording is not affected by maternal obesity or maternal and fetal movement because it's inside. So that's why these are benefits. Accurate assessment of fetal heart rate variability. It allows greater maternal freedom of movement without compromising the tracing. Again, compared to external, because they fall off. I'm sorry, I'm still here. Continuous internal fetal monitoring. The disadvantages are that the membranes have to have been ruptured to utilize the internal monitoring. So because we can't go through that, cervix is like the door. We can't go through that with a catheter or a monitoring device. It must be adequately dilated to a minimum of 2 to 3, and some policies say 4. So the cervix has to be open a tiny bit so we can slide this electrode on the infant's head. Presenting part must have descended enough to place the electrode on. That makes sense. Potential risk of injury to the fetus if the electrode is not properly applied. Contraindicated with any vaginal bleeding. With any vaginal bleeding, we basically assume that something is going on with the placenta, and no vaginal exams, nothing happens if they're vaginal bleeding. They need to have an ultrasound, abdominal ultrasound, to find out what's going on. And it's a potential risk of infection for the client and the fetus, simply because we're taking an instrument and placing it up there into the baby's head. And yes, it's sterile, but we all know that people can break sterile technique. And then the final disadvantage is that a doctor, nurse practitioner, midwife, or a specially trained RN must perform this procedure. So not just anybody can do it. A vaginal examination, when we do vaginal exams, they determine the presentation. What's presenting on this infant? Is it the head, the shoulder, the butt? The position, again, in relation to the mother's pelvis that we already talked about. Station, where they are in their descent into the pelvis. These are words we've already learned. The degree of flexion in the fetal head, swelling of the fetal scalp. Just kind of let you know how long they've been trying to get out. Status of cervical dilation, again, measured in centimeters. And status of effacement, which is measured in percent. And all of those are done by the vaginal exam. And now we'll look at a manual assessment of uterine activity. And this is kind of fun for you students when you do get into the clinical setting. It's what is the intensity? And we can actually measure the intensity by palpation or feeling. And these are fun to do because we all have a chin, a forehead, and a nose. But mild, if you the fundus is easily indented by fingertips, is softness similar to your nose. So we're pressing on the fundus, which would be the top of the uterus, and only if the mother's going to allow you to do this. But softness should be similar to your nose when you push it in. And most of us, there's no bones in the nose there. So at the end especially, so very soft. Moderate is pressure needed to indent the fundus. It's very similar to your chin. That's the moderate. And chin is much bigger bone, but it's kind of squishy too, but not as soft as the nose. And strong, it feels like our forehead, which is like a brick or a piece of wood. So there you have it. So it's kind of fun things that you can do on your own. But again, place your fingertips on the fundus that's outside, high on the abdomen. The fundus is the top of the uterus, not the bottom. And you'll be learning way more about the fundus as we move on. A fetal heart rate, I think I've already said, normal range is 110 to 160. Baseline changes to the fetal heart rate include tachycardic, bradycardic, and variability. A tachycardia, here's definition of 160 beats per minute or more for at least a 10-minute segment of time. So it's not to be confused with when it goes back to a baseline after the contraction. This is where they're not going to say they're tachycardic unless it's at least a 10-minute segment. And that's a long time when you're watching these things go in different ways. Bradycardia, same thing, is going to be for a 10-minute segment, but less than 110. Accelerations are normally caused by fetal movement, and they get stronger with contractions. And all accelerations mean is that the baby's SNS is intact, the sympathetic nervous system. When we're taxed at any way, physically, mentally, with stress, our sympathetic nervous system kicks in, and our heart rate usually goes up. Decelerations are categorized as early, variable, and late, and we'll look at those in a little bit. And again, I want to stress that accelerations are associated with stimulation of the autonomic nervous system, specifically the SNS or sympathetic nervous system. Elevated heart rate can also be associated with fetal movement, vaginal exams, application of the fetal scalp electrode, uterine contractions, any fundal pressure or abdominal palpation. And again, decels are decreased in the fetal heart rate below the baseline. An early deceleration is associated with pressure on the fetal head. So we don't get too concerned about it. It's a gradual decrease of the fetal heart rate from the baseline and return to the baseline associated with the uterine contraction. So an early deceleration is fine. It mirrors the uterine contraction. The onset, the nadir, or peak. You can cross that out and put peak. And recovery of the fetal heart rate occurs with onset and peak and ending of the uterine contraction, and it mirrors that. So that's fine, very normal. A variable deceleration is abrupt decrease in fetal heart rate from the baseline and return to the baseline. It's associated with a transient umbilical cord compression. So if this continues, we're not going to be happy, because transient means it's moving because the baby's moving. But we never want that cord to be compressed because that's what's bringing the baby the oxygen from mommy. That's the lifeline. May or may not be associated with uterine contractions. And a late deceleration is the one that we need to worry about. And you'll get to see what those look like soon. It's a gradual decrease of fetal heart rate from the baseline and return to the baseline associated with the uterine contraction, but it's delayed in timing. It's after the peak of the uterine contraction. Remember, we want it to mirror the uterine contraction, and late deceleration does not. It's associated, look at this, is very important to remember about lates. When you'll hear people say, oh, they're having a C-section for lates, they're talking about late decelerations. It's impeded perfusion of their intervillous space. Well, what does that mean? Well, it means hypoxia to the baby. Whenever you see uteroplacental insufficiency between the uterus and the placenta, that's also with the cord is attached to the baby, the lifeline to the baby. When it's insufficient, we have hypoxemia to the baby. A gradual or abrupt decrease in fetal heart rate from the baseline, at least 15 beats per minute, lasting greater than 2 minutes, is a prolonged deceleration. Reflects, again, disrupted oxygen transfer at one or more points along the oxygenation pathway. So we have to pay attention to the prolonged decelerations. Sustained disruption of oxygen transfer can lead to fetal hypoxemia, hypoxia, metabolic acidosis, and myocardial depression. If we have a, long enough myocardial depression, we are going to have asystole. So nursing interventions for the first stage of labor. Educate, educate, educate. They're doing okay now. They're not in severe pain. Encourage upright position, ambulation if it's not contraindicated. And I bolded it, extremely important to encourage voiding throughout this whole process. Before labor, during labor, after labor. That giant uterus sits on, presses on the bladder. It can cause all kinds of bladder infections, UTIs for these people, and even in early pregnancy, during pregnancy, and during labor, it gets in the way. It gets in the way of the baby coming down and out. Remember, and I usually show you with my hands when we're actually at a time when I'm standing in front of you, but the bladder actually sits, it's anchored right in front of the uterus. So this big giant gravid uterus that's like this big giant balloon pushes the bladder all over the place. And again, it can impede a delivery. And then afterwards, we want it empty because we want the uterus to be able to shrink back down to where it was so that they don't bleed. So first stage active phase, provide fetal monitoring, encourage frequent position changes all the time. That helps with oxygenation also. Voiding every 1 to 2 hours. Deep cleansing breaths, big deep breaths just help them oxygenate themselves, and in turn the baby will be oxygenated. Encourage relaxation only between the contractions. When they're having a contraction, they are not going to be able to relax. And then provide non-pharmacologic measures, which we will be looking at, if not this week, next week. And then pharmacologic pain relief as ordered. Okay, I'm going to end right here with the first stage, and then we will pick up with the transition in just a short time. Thank you.